Okay, I think everybody's pretty much back. So it is a great pleasure to introduce a colleague of mine from the University of Maryland, who, when I was at the University of Maryland from 1997 to 2002, was not yet there. You're probably still in residency or something somewhere.
I was a resident. We even saw the Winston kid.
That's right, at the resident there. And and the University of Maryland has got this exciting new technology that they've just opened up that he's going to tell you about, and then he'll run the session. So with no further ado, Dr. Young Kwok.
Can you guys hear me?
Are you plugged in?
I am plugged in.
Are you turned on? Press the button. Any second now it's going to explode.
Can you guys hear me? No?
Wait, hold on. He's going to turn you up a little bit. Keep going.
I'm told I'm too loud, so nice surprise.
And we'll just set this, you're going to do.
Yeah, so my name is Young Kwok. I'm a radiation oncologist who treats most of all the pediatric tumors at University of Maryland, and a significant portion of the brain tumors, adult brain tumors. And I appreciate you guys inviting me to talk, both Jeff and Jeff. And I'll try not to make this a University of Maryland thing because, as you'll see, we're in an exciting time. After a lull of several years, I think all of a sudden we have the opportunity to offer something very, very sophisticated to our patients in the Baltimore, Washington metro region, Northern Virginia. Usually in radiation oncology, we don't get too much time to talk. So I took out a lot of this research slides, and it's gonna be a little bit more laid back. A lot of pictures and a video. So how do I? There it is. So when we talk about radiation, we're always talking about therapeutic index. We try to deliver as much radiation to the tumor as possible, while we minimize tissue dose to the normal tissues around where we're aiming the radiation at. And this is a simple concept, but it's extremely difficult to achieve in many cases. So let's say you have a deep-seated brain tumor. Well, you have to get to the brain tissue, get through the brain tissue to get to the tumor. And for a long time, when we use radiation, we use what we call X-rays or photons. And this was just very difficult to achieve in many of our patients. Now, we have something called protons, where it's very different than your conventional radiation. And really, there is no doubt now that proton beam therapy offers the best dosimetric advantages. So on paper, in front of the computer screen, there is no question that it offers a superior dosimetry, radiation cloud, compared to photons. Whether that translates into a meaningful outcome difference is something that we have to do. We have to prove. Next slide, please. There it is. And so proton radiation, proton beam, it started to take off. There are some historic centers. Got Loma Linda, Mass General, or the Harvard Cyclotron lab. That they were the two historic centers for a long time. Then MD Anderson was built, and Penn, and so on and so forth. And now, I mean, every month, every couple of months, the numbers this slide keeps getting outdated. There are a bunch, dozens that are in planning right now. And then, not in just this country, but but countries all over the world. And why? Why is there been such an excitement with proton therapy? Oh. Okay. It's because protons, some of you have seen this already. We have something called Bragg peak. And this blue curve is what happens when you shoot X-rays, or what we call photons, into tissue. This bottom portion continues on. It's an asymptote. It never reaches zero. So you can put a 100-meter lead in metal or bricks or concrete, and you shoot radiation, you'll detect photons at the other end. Protons is very different. It comes to a distance and then gives off radiation. And we can spread this out and we can control it. So there's very little exit dose, virtually no exit dose. Some of you guys may have heard of carbon ions that has even more sharp Bragg peak. But the problem with carbons is there's some exit dose. So we think protons is going to be the more affordable solution. Carbon is even more expensive. And so this is sort of the wave of the future. Can you go to the next? Oh, there it is. So protons stop. I got a point here, right? Next. So this is sort of a graph, what we're talking about here. So X is X-ray. You have integral dose and conformality, how conformal it is, how much it hugs around, how well it hugs around the target. And integral dose is total energy deposited in human body or tissue. And the higher the integral dose, the higher your risk for secondary malignancy, theoretically. So you want to limit the integral dose while increasing conformality. It's a classic curve here. You have X is here, and P is protons, and C is carbon, and this is debatable. But intensity-modulated proton therapy is it's the new technology. That's the standard now. The older technology was what we call three-dimensional proton therapy, and that's what we call passive scattering. And all this does is it really increases how exact we are in delivering the radiation and lowering the integral dose. So less energy deposited in tissue is the way to go. And this has a special benefit to pediatric patients, which I will go into more in detail. Next slide. So this is what we do for a long time in most centers, and including our center just not too long ago, where we give, this is craniospinal radiation, where you're treating all of the brain and spine, the entire CSF space. So we're talking medulloblastoma, PNETs, and old days, non-germinal stem cell tumors, and so on and so forth. And all this exit dose to the heart, to the lungs, to the breast. And if you look at all of the population studies, kids who've gotten medulloblastoma, craniospinal radiation, or radiation, they all have increased risk slightly of breast cancer, lung cancer actually. They have a higher incidence of esophageal cancer, and they have a higher incidence of cardiac toxicity later on. And in protons, next, because of the stopping radiation, next slide, it just stops. So we're able to spare all this tissue beyond the spine. Okay? And we've done many, many plans at our center, and this is very exciting. So how are the protons produced? Now, I don't have too many of these non-picture slides, but it comes from hydrogen. Remember basic middle school or elementary school or even kindergarten, depending on how advanced your school system is. Hydrogen has electrons and protons have single proton, and the protons are separated in a vacuum tube called cyclotron, and it is accelerated. Okay, and it leaves the cyclotron, and it's bent in multiple ways, and it gets directed with giant magnets into where you want to deliver the radiation. When we're talking giant, we're talking tens and tens and tens, hundreds, and together tons gantry. Okay, into the treatment room. In the cyclotron, it accelerates the protons, and this M is mega. So 70 to 200, that's our most centers in the 70 to 250 mega electron volts. Lots of energy. It travels approximately at the end about 2/3 the speed of light. And in order to go from the hydrogen all the way to the patient, it travels, 300,000 miles eventually. And this is the reason why most of the early proton centers were sort of the byproduct of research cyclotrons. So it was really an offshoot of many physics departments. And I will talk about pencil beam in a second. But pencil beam was pencil beam scanning, or active, or what we call intensity-modulated proton beam, was first devised in 1996 at Paul Scherrer Institute in Switzerland, outside of Zurich. That's a giant, as you guys may, some of you guys may know, it's a giant research institute where part of that was being funneled to for this technology to be developed on human beings. I spent some time there. It's enormous. It was so complicated that it took the rest of the world about 15 years before they could replicate it in commercial form. Okay? That's how complicated this stuff is. Next slide. Okay, so the old way of doing this was a very cumbersome method. I think a lot of it was, sometimes people who are doing it, they're so upset how complicated, how much work they have to do. They say, there's got to be an easier way. And I think that's a driver of many things in life. But it was just a very complicated way to shape the beam and shape each beam in each patient. And it was very cumbersome, cutting out multiple metal structures and so on and so forth. And this is the old, what we call passive scattering. Next slide. On the left is passive scattering. And the right is what we call pencil beam scanning. It's the modern. And I'll show you a video. I know some of you guys have already seen the video. Right? Yeah. As you can see on the left, the old method, the whole beam comes out. So you have to individualize each field. The whole beam has to be shaped with metal cutouts, blocks, you would call it. It's very conformal at the distal end, but not so conformal at the proximal end. Pencil beam, you put in tiny pencil beams, tiny spots at the tumor. And in all my years of doing this, or a couple of years actually, but just recently, a couple months ago, my patient told me that this looks like 3D printing, and I'm going to use that. So let me show you the video. This is our layout. It takes up a whole city block, by the way. This is miniaturized. So anywhere from 70 to 250 mega electron volts. And these are giant magnets. And we have 5 rooms. And can you play the video? And this is how, in concept, it's going to be. This is identical to our room. And most modern, all of the ones that are going to be built at Hopkins, and Sibley, and Georgetown, it's pencil beam, which is great. And in general, it's very similar concept. Just it looks physically different. So we do a CT or an X-ray to make sure we're aiming correctly. Okay, this is the patient. An example is a lung tumor. You see what it means to sort of picture what a 3D printer prints, how it does it. It's very similar. It goes much faster than this. So it paints one layer, paints another layer, and so on and so forth. It actually happens much quicker than this. I guess this is how 3D printer works. Huh?
How much margin is it?
It depends on the case. So anywhere from 3 to, high-grade gliomas, we're talking 2 centimeters. Depends on the clinical, but that's what we call clinical target value, where we have to cover microscopic disease, right? So Raptors, Ewings, they can be large. And there's nothing deep to that. There's very little dose deep to that, and I'll show you some pictures. Okay? Can we go to the next slide? So let's look over, I'm going to go through some of these quicker. So chordomas, there's no question. Historically, chordomas, the best clinical outcomes you'll ever see are done from on protons. And the reason why is because the brainstem and other brain tissues are so close. And it's very hard, and I've done it with regular radiation, it's very hard to dose escalate to the proper dose because you have significant exit dose. So if you look at the Mayo Clinic series, there was only a 32% 5-year local control with surgery followed by regular 3D radiation, and some of them even got gamma knife. But at PSI, Switzerland, Paul Scher Institute, Mass General, the clinical local control is at least double. And this is a consistent pattern. And this begs the question, would you ever want to be a this is the whole issue of, ethics of, could you even do a randomized trial on this? Because it's so consistent in the literature that it'd be very tough to get a trial like that going. It's one of the challenges right now. Next slide. In pediatric tumors, I'm going to quickly go to the rest. 85% of pediatric tumors are cured, about half get radiation, and there are long-term consequences to the radiation. Growth disturbances, hormone disturbances, infertility. 2/3 will have long-term health conditions, and 1 out of 5 would die from either a second malignancy or treatment-related complications. And I'm going to go through some of this quick. Next slide. And we've done studies on medulloblastoma to know that cochlear dose and heart dose is much lower with protons on the bottom. That's just percent. Next slide. I'm going to go through some of this. We have second malignancy cancer risk calculations. IMPT is really much lower than all other conventional radiation. Next. We have Mass General data. It's kind of controversial, but they published some of the first clinical outcomes. Second cancer is 12.8% with photons, 6.4%, about half with protons. Of course, when this was presented, I was there. Somebody asked, well, how can you tell me the protons patients are same as the photon patients? And it's really, really, really a great question. In this historical series, people who were able to afford to get protons just had from different socioeconomic status. Now, hopefully, next slide, when we have multiple machines throughout the centers throughout the country, we have more and more patients, all that socioeconomic issues will start to get equalized, and we'll find out whether protons indeed are associated with lower second malignancy. This is a case of a kid 9 years after cranial spinal radiation who this is what we're trying to prevent, got radiation, this exit dose, and at the exit dose there was a sarcoma. And this has all of the hallmarks of a radiation-induced sarcoma. It is occurring at the lower distal end at the lowest dose. These are the cells that survive with mutations to develop into sarcoma. It had a sarcoma, usually it's the most common radiation, it's a classic radiation-induced malignancy, it's a sarcoma. And it's occurring in a very unusual location for a soft tissue sarcoma. All of the hallmarks of a radiation-induced sarcoma. Okay? Let me just skip that. Can you go to the next slide? So, there are clinical studies on retinal, pelvic sarcoma, bone sarcomas, randomized sarcomas that really speak to the advantages of protons over regular radiation. Next slide. I'm going to skip some of this. And then, of course, with the big talk in the field right now is cardiac toxicity. It's the Darby paper, New England Journal of Medicine, a few years ago, that demonstrated that there is no safe dose of cardiac dose of radiation. And it was a relative 7.4% increase in cardiac toxicity with each grade of radiation. And there is no safe dose. Okay? Same thing with Hodgkin's disease. The paper from last year, there's no safe dose for Hodgkin's. In fact, the 7.4% per grade is almost identical with this analysis, the Dutch paper. Next slide. So this is what we're talking about. This is breast cancer, treated with chest wall, treated with protons, planned with X-rays. And this is the excess radiation dose. And imagine anteriorly, there's a Hodgkin's lymphoma there. The radiation would stop before it gets to the heart. This is esophageal cancer. All that heart, liver, lung doses much lower on the left. Brain tumor. This is all the excess radiation. This is the left temporal lobe. The more important of the, here's a tumor. This is protons and all the excess radiation. This is the excess radiation on the right that we can avoid with protons. Just got one more minute. Liver cancer, stereotactic body radiation is hot in liver cancer, HCC. Many of these people have cirrhosis, and this is one way to lower it. This is incredible stuff. Heart, this is all the excess radiation dose that you go in. I mean, lung cancer. Protons, there's no dose to the left lung. Now, I think my last slide. I might skip this, okay, because I'm running out of time. So my last slide is that in the Baltimore, Washington area, in a span of just a few years, we have 3 centers. Okay, we're operational right now. We're up to 2 gantries. Probably next month we'll go up to 3rd gantries. Every 2 to 3 months we're having one open up. There are many reasons why we're slowly opening it. There will be 5 rooms total. I was told in June of 2017 there's a Georgetown will be open. I'm going to say summer of 2017 because this is no proton center ever opens on time. That's the rule. Okay? And Hopkins, I put a big range there. 2018, 2019, they have a multi-gantry center with Hitachi as their vendor. And all 3 centers will have IMPT, pencil beam scanning capabilities, the latest technology. And so when we have all this open, we have more patients who are eligible for it. The battle we're fighting right now is the insurance company. But hopefully they will come to their senses. Okay? Thank you for allowing me to talk, and that's it. Any questions? Good. So, great question. We were the 2nd center in the country, Mayo, and I heard there's another center, the the one intensity is also cost neutral. We're cost neutral. So it's same as IMRT. Protons is same as IMRT. Historically, it's been 2.5 times the cost, so the insurance company get billed two times the cost. We've went to a cost neutral model where it's the same. We thought that that'll make the insurance company see the logic and approve everyone, and that's not the case. Because a lot of the rules they have were set up, policies were set up when the protons were much more expensive. And it's just the inertia, like it's very hard to change that unless they go back and change their whole policy. And that's the thing that, so there's a second, third appeal, and there's a final appeal, and then they finally come to their senses. But it's like a month process of getting insurance for that.
Before breast tumor, but with genital tumor, do you inject mercury into the pleural space temporarily to protect the lung part and then take it out?
Yes and no. You mean from the radiation, right?
To protect radiation. So inject mercury, fill the pleural space.
Yeah, but you can't put enough. You can't put enough metal in the space to block all of it, and then you gotta take it out, right? So, but we think protons, when you come a single anterior like this, you don't need to inject anything because it stops right at the chest wall.
Photon therapy is, if we treat our tumor with 54 gray of photons, is it necessarily the same dose? Do we have to redefine the amount of radiation to give each of these tumors?
With protons, right?
With protons.
Yeah, we've taken it, it's a 1.1 to 1 ratio, we'll go RBE. And we have now done all that, and it's pretty much equal. Like, it's a set. Should we do all those studies all over again with protons? The answer is theoretically, yeah, but it's not going to happen in a lifetime because now we assume that they're equivalent in dose, and it's just logistically impossible to do all those studies all over again. But we're doing like phase 2 rhabdo. There are different complexities with protons that we have to answer right now before we can even do those studies. Okay, we gotta move on.